So this is page 224A. The purpose of looking at this page is these are the most common blood tests that are run on people. Now obviously they can run thousands of different blood tests, but many of them are rare and exotic, very expensive, and they only occasionally need to run them on certain specific individuals. But these are the most common blood tests that are run, whether it's having a general physical examination where they draw blood at a doctor's office, or whether you're admitted into a hospital, they're going to immediately run a bunch of blood tests on you. Standard. Now, the only information we're given here is that it's a female. All right? Could have been a male. In this particular lab form, and the way these different blood test lab forms present the data varies. In this particular form, you'll notice they measured, in this case, a chemical, glucose, and they indicated what the glucose concentration was in this patient's blood. Now, if the value, if the number, when they measured it, is in the normal range, they wrote it above the dashed line. But if the number they measured, if the number they got, was either lower than normal or higher than normal, they wrote that number below the dashed line. There are other labs where, if you've ever seen it, has anybody ever looked at your blood results of blood tests? Very commonly, they'll write down the number, and they'll write next to it, printed next to it will be either a capital letter H or L. Meaning, if it's higher than normal, they're indicating an H, that they're pointing it out, this is higher than normal. Or they'll put an L, capital letter L, this is lower than normal. And if they don't have an H or an L, then it means it falls within a normal range. So there are a lot of variations on this, but the whole idea is that the clinician, the nurse practitioner, the physician's assistant, the physician looks at this data and they're trying to evaluate the patient to diagnose what's wrong. So let's just start in this top row, and in the first two rows, you'll notice that it's labeled chemistry. This is blood chemistry. They are measuring chemicals in the blood. And we're kind of look at this because this is a wonderful way to summarize many things that we've been learning about in this entire course. All right, so the very first thing they measured was the glucose level in the blood. We know, and you must know for the final, that the normal glucose level in the blood is about 100 milligrams of glucose per 100 milliliters of blood. That's also written as 100 milligrams per deciliter or 100 milligrams per cent. You have to be able to recognize it no matter which form we write it in, because there's no consistency. We've learned about that back when we had that lab test. All right, so SIRS was 103. Clearly, that's close to 100. There is a normal range. It's you can't really make it out, but it said 60 to 115. We're not asking you to know the normal range, but just it's such an easy number, 100, to have a ballpark idea of what a normal blood sugar level is. Anytime they draw blood from you, they're going to measure your blood sugar level. That is so basic, so fundamental. They've got to know. Do you have hypoglycemia? Do you have hyperglycemia? Now, of course, we have learned that there are many hormones that affect our blood sugar level. The two major hormones are insulin and glucagon. And we've just been tested on that. In fact, we originally learned about them back for the first exam in section B in regulating our blood sugar level. Sugar is the major food that is broken apart in cellular respiration to make ATP. There are many other hormones besides insulin and glucagon that regulate or have an effect on our blood sugar level, including adrenaline, epinephrine, and also including glucocorticosteroids like cortisol, whole growth hormone, and so on. So there are a lot of things that can affect that blood sugar level. All right, now we're not going to cover everything on this chart, but we're going to learn a lot. So this next thing that we're going to look at is the BUN level. Have we ever learned BUN? The BUN stands for what? Blood urea nitrogen. If you don't remember it, we needed to know it for the first exam. We covered it in section B. The urea is the major organic waste circulating in our bloodstream and filtered out and excreted in our urine. Ammonia and urea, mostly urea, it's formed in the liver from the breakdown of old proteins. And during the deamination of the amino acids, this organic waste is formed called urea. Her urea level fell within the normal range. All right, now right next to it, creatinine. Now, creatinine, I believe we mentioned the last class meeting. What did we say about creatinine? Some of you were here, some of you weren't here. Creatinine is a waste product, an organic waste product formed where? In our muscles. Yeah, you have to know it. Yes, I talked about it, and yes, it's on the video. All right, so creatinine is the third major organic waste that's circulating in our blood and excreted in our urine. The number 1 waste is urea. The number 3 waste is creatinine. Now, a chemical that sounds like creatinine a little bit, and it's related, is we have learned that there's an enzyme found only in muscle cells. And what's the name of that enzyme? What's the abbreviation of the enzyme? CPK, creatine phosphokinase, right? And we've talked about it not only in our lab, for our lab test. You'd say, yeah, but that's not on the test. Yes, and we also mentioned it more recently for the exam you just took, because we said that if somebody has myocardial ischemia or myocardial infarction, enzymes leak out of those damaged heart muscle cells, including CPK. So that we've just spoken about more recently. So, and it stands for creatine phosphokinase. Creatine phosphokinase sounds very similar to this waste product called creatinine. And both the CPK levels leak out of the injured muscle cells, and so does creatinine leak out of the injured muscle cells, and these levels rise in the bloodstream. There are other chemicals that we didn't have time to talk about, like troponin. That is another protein found in muscle cells that leaks out into the bloodstream as well. And these are all used as indicators of the severity of the injury. All right, let's just mention, if urea is the number 1 organic waste, and creatinine is the number 3, so let's just remember the second one. It's listed in the second row, uric acid. So uric acid, we originally learned about in section B. We needed to know it for the first exam. Remember, our final is comprehensive. You need to know everything we've been learning about in this course. So uric acid, we learned, is a waste product formed largely in the liver from the breakdown of nucleic acids. So that is the second major organic waste. Now, in fact, they measured this woman's uric acid level, and you'll notice they put the number below the dashed line because it is higher, it exceeds the normal range. And the normal range is a little bit lower for females than males. All right, but hers is higher than the acceptable range. So she has what we would call hyperuricemia, which creates what disease, what disorder? Gouty arthritis. All right, we learned that back in section B. Now, so we see that in her case, only her uric acid waste product levels were higher than normal. Her urea and creatinine levels were in the normal range. Fine. So she just has a problem with uric acid. What do you think it would mean if her urea level in her blood was higher than normal, her creatinine level in her blood was higher than normal, and her uric acid level was higher in her bloodstream than normal? What do you think if all of these waste product levels are higher than normal? What do you think most likely explains that? Kidney failure. It would be if only one of the waste products, like uric acid, is higher than normal. So then it's a specific disorder related to uric acid. But if all the waste product levels are higher than normal, it's not likely that the person suffering from 3 different diseases or disorders, there's one disorder that would explain all of those waste products being higher than normal: kidney failure. The job of the kidneys is to filter out and excrete these waste products. If the kidneys aren't working, then all of the waste products will be accumulating and rising in the bloodstream. What I'm trying to introduce you to is the way that clinicians look at this data and try to interpret, what does this mean? What's wrong with that patient? Okay, let's return back up to the top row. And what comes next is AST, ALT, LDH, GTP. What the hell are those? Those are enzymes. Those are enzyme levels in the blood. We learned something really cool for our lab test. We learned that anytime different tissues are injured, there's a disease or injury to different tissues, enzymes that are in those different tissue cells leak out into the bloodstream, and those levels of enzymes rise in the blood. So depending upon which enzyme levels are higher in the bloodstream than normal is an indicator of which tissues have been injured, where there's a disease or injury to different tissues. So as an example, to talk about one that we learned about, ALT, alanine aminotransferase. So ALT is specifically an enzyme found only in the liver. It's found only in the liver. So if you see, now her liver enzyme level is normal, but if her liver enzyme level was higher than normal, it indicates there's something injuring her liver. So we have learned that Lipitor, the drug, can actually injure the liver, and the way you would know that is you start to see increasing levels of that liver enzyme level in the blood. That's known as a, quote, liver function test, right? So that's, they can measure various enzyme levels that are indicative of injury or diseases of different tissues or organs of the body. Really clever. Okay, now, next thing here, bilirubin. What is bilirubin? Nobody knows what bilirubin is. Bilirubin is a waste product formed from the breakdown of hemoglobin, which occurs largely in the liver. It's all described in my video on hematology. So it is formed in the liver from the breakdown of hemoglobin. Now, whenever the bilirubin levels are higher than normal, that's called hyperbilirubinemia. And these elevated, bilirubin itself is kind of a greenish-yellow chemical. And when the level of this greenish-yellow bilirubin increases in the bloodstream, it causes a yellowing of the body called jaundice. Now, there are many things that could cause elevated bilirubin levels, but since it is mostly made in the liver, one of the things that can cause elevated bilirubin levels higher than normal is liver disease. People commonly with liver disease develop elevated levels of bilirubin, and it's manifested by the symptoms of jaundice. There are other things that can cause elevated bilirubin levels. Now, bilirubin, this greenish-yellow chemical, yellowish-green chemical, is produced by the liver, and does anybody know what happens to it? Normally, it's formed in the liver, and then it's secreted with the bile. It's what gives bile its greenish-yellow, yellowish-green color. It's due to the bilirubin formed by the liver. Now, you all learned about bile from anatomy. I'm sure you did. So there are bile ducts. And these bile ducts carry that bile from the liver, where it's made, to where? Okay, well, it's connected to the gallbladder. All right, bile can be stored in the gallbladder, but where does it go to? Whether it's coming directly from the liver or from the gallbladder, it's carried by the common bile duct to where? This is basic anatomy. Nobody knows where bile goes. You've all heard of it, have no idea. It connects to the duodenum, the duodenum. So the bile is formed by the liver, stored in the gallbladder, and carried by the common bile duct to the duodenum, the first segment of the small intestine. Okay, great. Now, what is bile for? Does it actually break down fats? It's not an enzyme. Enzymes digest or break down stuff. It emulsifies fats. What does emulsify mean?
Mixing up with the water.
Exactly. It allows fats to mix with water. So there are fats in our foods. We eat butter and margarine and cream and cheese and fat and vegetable oils in our salad dressing. There are fats in our meat, but fats don't mix with water. If you take vegetable oil and you mix it with water, they separate. The oil floats on top. But every time you put salad dressing, you're ingesting vegetable oils. There's vegetable oils in all the bread and cookies you eat. Have you ever made cookies or bread? Okay? You either use butter, margarine, or vegetable oil. Okay? All right, so, but fats, oils don't dissolve in water. Before you can digest or enzymatically digest fats, you have to get them to dissolve or mix in water where the enzymes are. So the purpose of the bile is to emulsify fats. That means it allows the fats to dissolve in water. That's the purpose of bile. When I present this in anatomy, and if you had me for anatomy, you know I cover this, whether you remember it or not. I refer to bile as the original simple green. Because what's simple green? It's like soap that'll dissolve anything. right? You got grease or oil on a table, on a floor, spray some simple green. Oh my gosh, the oils and fats, they dissolve right away in my wet washcloth with water on it. So it's like the original simple green. What gives it its green color is bilirubin. Okay, but anyhow, we're getting off track here. But these chemicals all have a purpose. And the job, the understanding of the human body is what are these chemicals for? So anyhow, elevated bilirubin is formed, can occur for a number of reasons. And again, it is formed from the breakdown of hemoglobin. So please watch the video. If you have questions on it, I'll be happy to answer your questions on Thursday. All right, now, after bilirubin, mentioned some other enzymes and stuff, and then it says on the right, calcium. Now, I did not ask you to memorize what the normal calcium level in the blood is. You do not need to know it. But what and our calcium level in our blood is normal. But what we have learned more recently, and just been tested on, is the two principal hormones that regulate the calcium levels in the blood. What are they? Parathyroid hormone and calcitonin. Parathyroid hormone stimulates osteoclasts to break down bone tissue and release that calcium into the bloodstream. And conversely, calcitonin activates the osteoblasts to take the calcium that's in the bloodstream and deposit it in the bone. That's called ossification, or a deposition of calcium in the bone. So together, those two yin and yang, very similar to how insulin and glucagon regulate our blood sugar level, parathyroid hormone and calcitonin working together should maintain our calcium level normal. We've learned why calcium is so important. We actually learned this way back for the first exam when we enumerated the vitamins and minerals of the body near the end of section A. And at that point, we told you calcium is especially important for muscle contraction. We've talked about that more recently with respect to the heart, and also blood clotting. So very, very important to regulate those calcium levels. Okay, so we've been identifying what some of these chemicals are in that top row, and what it means if they're higher or lower than normal. All right, in the second row, it continues with chemistry. And we, in this class, haven't said that much about phosphorus or magnesium, but we have presented extensively, we've spoken extensively on sodium and potassium. Of all the minerals in the entire body, this arguably the single most important mineral or electrolyte of them all is potassium. We've asked you to memorize that the normal potassium level in our blood and other extracellular fluids is approximately 5 milliequivalents per liter. It's approximately, right? It's an easy number to remember. We've talked about we've learned most recently what regulates the potassium and sodium ion levels in our bloodstream. That's the renin-angiotensin-aldosterone reflex. Very, very important. And that's why hyperaldosteronism, too much aldosterone, or hypoaldosteronism, too little, leads to changes in the sodium and potassium electrolyte levels, making it really, really important. We've talked about the danger of hypokalemia. If the potassium level in the blood and other extracellular fluids becomes lower than normal, it causes a slowing down of all electrical activity of the entire body. On the other hand, hyperkalemia, elevated potassium levels in the blood and extracellular fluids cause an overall increase of electrical activity throughout the entire body. So very, very important. We've learned what can cause hypokalemia and what can cause hyperkalemia, back on pages 41 and 42. So potassium is what determines, the extracellular potassium level is what determines the electrical voltage of every cell in our body. Now, the second most important mineral in our body, or electrolyte, is sodium. Sodium is needed for the generation of action potentials. All right? So, and again, it's the renin-angiotensin-aldosterone reflex that regulates this. So this is physiology. This is medicine. We're learning what all these chemicals do and how they're regulated and what it means if they're higher than normal or lower than normal. Because if everything's working right, if we measured all these chemical levels in your blood and they're all perfect, you're probably perfect. You're normal. You're fantastic. And you don't need a doctor. Where you need a doctor is when these chemical levels are not in the normal range. They're higher or lower than normal. Why are they not in the normal range? They should be. So there's something wrong. The control and regulation isn't working. All right, looking here, we're going to talk more about carbon dioxide as we move on to the respiratory system. We've already spoken of uric acid. So just to the right of uric acid in the second row, it says triglyceride level, cholesterol, HDL, and LDL. Now, these are really important. This is the measurement of fats in the blood. When they measure these, and they commonly do, this is commonly known as the lipid panel. Has anybody ever heard that term? The lipid panel. That's that part of this panel of tests that is basically describing fat levels. Now, they measured this woman's triglyceride level. Oh my gosh, it's way higher than normal. I didn't ask you to memorize the normal level, but it tells you what the normal range is. It's not supposed to be higher than 160 milligrams per deciliter, and hers is 254. They measured her cholesterol level, and her cholesterol level is 317. Do you remember us learning that the cholesterol level should be below, less than 200 milligrams percent, less than 200 milligrams per deciliter, less than 200 milligrams of cholesterol per 100 milliliters of blood? Hers exceeds that. Now, we've talked about last class meeting HDL and LDL. If you weren't here, it's on the video. It's also in the book. HDL, LDL. Which one's the good one? Which one's the bad one? HDL is the healthy one. LDL is the lethal one. What are they? They're lipoproteins. They are proteins produced by the liver. LDL, the bad one, transports cholesterol from the liver to the tissues of the body, including the walls of the arteries. Unfortunately, her LDL level is way too high. That means she's probably transporting too much, excessive amounts of cholesterol to the walls of her arteries, leading to atherosclerosis. Her HDL level, the good one, that actually transports cholesterol from the tissues, including the walls of the arteries, and returns it back to the liver. Again, we talked about that. So that's in the normal range. But the most important of all these is that LDL level. That's the most critical. So she's in big trouble. You'd say, why? Look on the back side. So on the back side, look towards the lower left. So on the lower left, on the back side of this, it says cholesterol, triglyceride, HDL cholesterol, LDL cholesterol, and the ratio of cholesterol to HDL. All right, and here it indicates her risk of coronary heart disease. You'd say, what's coronary heart disease? That's another way of saying coronary artery disease, CAD. So whether we call it CAD, coronary artery disease, or CHD, coronary heart disease, it's the same thing. What is that? The buildup of atherosclerotic plaque on the inner walls of the coronary arteries. You'd say, was that important? No, it's just the #1 cause of death. Other than that, don't worry about it. The #1 cause of death is heart attacks. A myocardial infarction caused by a coronary thrombosis triggered by coronary heart disease or coronary artery disease. Now, again, we can be impressed with what we're learning. As you listen to my words, if somebody walked into this classroom who hadn't learned what you have, do you think they'd understand most of what we're talking about? No. But you do. So you've got the jargon. You're picking up the clinical jargon. You're following what we're describing. All right, that's what this course is about. All right, so she had a cholesterol level of 317. Well, that's greater than 240. She's at high risk of coronary heart disease or artery disease. Her LDL level was, what was it? Her LDL was 233. Wow, that's way higher than 160. So in other words, she is at very high risk of dying from a heart attack. That's basically what it means. So they better put her on something, basically. Yeah, so the kind of drugs, so what are they going to give her? They're probably going to give her not only a drug like Lipitor, atorvastatin, to lower her cholesterol levels, they're probably also going to give her an anticoagulant or blood thinner, all right, to reduce, whether it's a tiny baby aspirin or whether it's something more powerful like clopidogrel, Plavix, or even Coumadin, because her levels of fat are so high that she's at high risk of forming a thrombosis, a blood clot. All right, so now we don't know what her blood pressure is. That's not a blood test. If we knew what her blood pressure is, it's very likely she also has high blood pressure, because we've learned that the most common cause of high blood pressure is atherosclerosis, right? That causes what's called essential hypertension or primary hypertension. If she's got high blood pressure, so then she's going to be on antihypertensive drugs, including perhaps a beta blocker, and to block the sympathetic response and try to lower that blood pressure. And she may be on some diuretic type of drug that it reduces that renin-angiotensin-aldosterone reflex. Okay, now, so we've been talking about the lipid panel. Okay, now, the next thing is the total protein level. So we covered this. I lectured on this on hematology. Right on the bottom of the first page of hematology, we learned that the major chemical dissolved in blood plasma is protein. And the normal protein level in our blood is 7%, which means 7 grams of protein in every 100 milliliters of blood. Right? It says 6 to 8. We learned the number 7. It's an easy number to remember. Hers is 7.6. It's totally normal. All right? Now, we also talked about, again, maybe you were here, maybe you weren't here, but you're still responsible whether you're here or not. What's the major protein in our blood? Albumin. That's why it's listed next. Albumin makes up 60% of the protein in our blood. The major role of albumin is it's responsible for the plasma colloid osmotic pressure. Remember, the presence of proteins in the blood are what draw water from the tissues back into the capillaries. Since the major protein is albumin, that's the major function of albumin, to reduce edema. Now, after albumin, we said there are all those alpha and beta globulins. So here in the third row, it says globulins. We learned last time when we lectured that there are a whole bunch of alpha and beta globulin proteins, most of which are produced by the liver, and they are involved largely in the transport of fats and minerals in the bloodstream. Okay, we're going to skip the next few. And then we get to where they measured the white blood cell count, the red blood cell count, the hemoglobin, the hematocrit, and so on. This is sometimes referred to as a CBC. What's a CBC? A complete blood count. A complete blood count is they want to get the white blood cell count and the red blood cell count and the blood platelet count. All right? And we did mention in the lecture last time that the normal red blood cell count, start with that, is about 5 million red blood cells per cubic millimeter. It is always written in exponential notation. That's why when I wrote that as 5 times 10 to the 6, I wrote it that way, not just to be mean, but I said that's the way it's always written. So here they indicate that the red blood cell count in males is a little bit higher than females. In males, it's 5.4 times 10 to the 6, which means 5,400,000. And in females, a little bit lower, 4.8 times 10 to the 6, that's 4,800,000. All right? We just said it's about 5 times 10 to the 6, 5 million. Okay, and there's a normal range. Hers was in the normal range for a female. Now, they also, if they found the red blood cell count lower than normal, what would we say she has? Anemia. Anemia, by definition, is a decreased number of normal red blood cells. Right? So she would have fewer red blood cells than normal. And what are the symptoms of being anemic? You're tired, cold and tired. Maybe gaining weight. Why? Somebody explain that to me. Why, if somebody's anemic, are they tired and cold and probably gaining weight? Huh?
Less oxygen for cellular
Yeah, exactly. If you have fewer red blood cells, you're transporting less oxygen in the blood. Isn't that what red blood cells are for? Okay, and why do you need oxygen?
or ATP.
For cellular respiration, to make ATP. Yes, we're back to cellular respiration. So if you carry less oxygen in the blood, the rate of cellular respiration slows down. And you produce ATP at a slower rate because you've got less oxygen. So if you produce ATP at a slower rate, you're tired. And we know that a byproduct of cellular respiration, over half the energy in the breakdown of sugar goes off as heat. So you're producing less heat, so you're cold all the time. And if you're breaking down food at a slower rate, so you're probably going to gain weight. Now, what other disorder could have those same symptoms? Hypothyroidism. You needed to know that for the most recent test. Why does hypothyroidism cause a person to be tired and cold and gain weight? The same thing! Because thyroxin affects the rate of cellular respiration. So whether the rate of cellular respiration is slower than normal because of less thyroxin, or it's slower than normal because of less oxygen, because you're anemic. So that means that if somebody comes to a doctor, maybe it's you, and you say to your doctor, you know, I'm tired all the time, I'm cold all the time, and I'm gaining weight, what do you think they're going to test you for? Thyroxin levels and your red blood cell count, whether you're anemic. I know it'd be nicer if that each problem had only one cause. But everything is multifactorial. You see similar symptoms that can be caused by different problems. Then you got to figure out what's the problem. Now, incidentally, if you got a reduced number of red blood cells, which is called anemia, there are many different causes of anemia. So if you've watched the video, we talked about iron deficiency anemia. We don't get enough iron because iron is part of the hemoglobin molecule. And there's something called pernicious anemia, vitamin B12 deficiency. And then there's something called sickle cell anemia. So then they got to figure out what's the cause of the low red blood cell count. We'll come back to that in a moment. Now, the white blood cell count, we asked you to know that the normal white blood cell count is about 7 times 10 to the third per cubic millimeter, which is 7,000 white blood cells per cubic millimeter, right? So notice they write 7.5 times 10 to the third. So it's about 7. So we measure the red blood cells in the millions and the white blood cells in the thousands per cubic millimeter. And we explained what a cubic millimeter was last time I lectured, which is equivalent to a microliter. All right, now what would it mean if they measured this person's white blood cell count if it were higher than normal? They have an infection. What are white blood cells for? To fight bad guys. Bacteria and viruses. So if you've got what's called leukocytosis, elevated white blood cell count, so you're fighting an infection. That's the indicator you probably have an infection. You may have other symptoms. Maybe you have a fever. Maybe you feel you've got other symptoms. But you may not even have a fever. But if you show an elevated white blood cell count, you're fighting an infection. All right. Now, HGB, that's the hemoglobin. So we've asked you to know that the normal amount of hemoglobin in our blood, in every 100 milliliters of blood, there's 15 grams of hemoglobin contained in the red blood cells of every 100 milliliters of blood. So it's 15%. Notice in males it's 16%, 16 grams per deciliter, 100 milliliters, and in females it's about 14%. We asked you to know 15 as a normal number. Now, hemoglobin, why would they want to measure the hemoglobin? Because it's possible that somebody could have the correct number of red blood cells. They might have 5 million red blood cells, but they may have less hemoglobin in their red blood cells than normal. You'd say, why? Because maybe they don't have enough iron in their diet, and iron is needed. It's a constituent. It's part of the hemoglobin molecule. So even if you had the right number of red blood cells, they might have less hemoglobin in those red blood cells than normal. And therefore, if they have less hemoglobin, they transport less oxygen. Because the oxygen works by binding to the iron of the hemoglobin. All right, now they also measured the HCT. What's the HCT? The hematocrit. I lectured on the hematocrit. It's on page 2, page 1 and page 2 of the hematology. So maybe you were here, maybe you weren't here. What's the hematocrit tell us? What's another name for the hematocrit? There's another name. Percent PCV, packed cell volume.
Do we have to know that?
Yes. Because sometimes it's written in the hospital as a percent PCV and sometimes it's written as HCT. I know, you're thinking, why don't they get their act together and just call it one thing? I know, I agree with you, but they don't. 100 milliliters is the same as a deciliter. You have to know that. You see deciliter written, it's the same as 100 milliliters, which is a percent. All right, so the hematocrit, we said that if you centrifuge or spin blood, it pulls the cells down to the bottom of the tube and the lighter plasma rises to the top, so that normally the cells make up about 45% of the blood volume. That's called a hematocrit, or percent packed cell volume of 45%. All right, so we learned the normal is 45%. It's actually 47% in males and 42% in females. Okay, so there's differences in blood cell counts in males versus females. That's primarily due to the presence of testosterone. Testosterone causes increased numbers of red blood cells and increased a proportion of blood cells in males. Obviously, that contributes to not only guys having greater muscle mass, but they've got also these additional blood cell counts that allows them to run faster on average than females. Okay, so anyhow, that's the hematocrit. Hers is in the normal range. We're not going to worry about MCV, MCH, MCHC. These are all additional ways of evaluating or assessing which type of anemia the person has. We're not going to get into that. In the next row, notice this is called hematology now. This was called hematology up here as well. Hematology is the study of those blood cells. When they were measuring chemicals, that was called chemistry. When we're measuring blood cells, we're talking about hematology. So they measured the platelet count. Now, we did not ask you to memorize the normal platelet count. Hers is normal, but we certainly know what platelets do. Blood platelets are also called thrombocytes. They are formed in our bone marrow. They're little fragments of cells formed in our bone marrow. They circulate in the bloodstream, and they're designed to aggregate or attach to rough surfaces, such as the cut edges of a blood vessel. And when they attach, they form a platelet plug that releases a chemical called platelet factor that initiates a series of chemical reactions that culminates in the formation of a fibrin clot. Okay, and if you watch the hematology video, I expand upon that and go into more detail about blood clotting. All right, so her platelet level is normal. All right, what do you think they call it if the blood platelet count is lower than normal? Thrombocytopenia. Penia means low. You know penia means low. You'd say, well, I didn't watch the hematology video. How would I know? Because we had to know for the most recent exam the term lymphocytopenia. Because glucocorticosteroids like cortisol and synthetic glucocorticosteroids like prednisone lower the lymphocyte count. And when you lower something, when it becomes lower than normal, we use that suffix ending penia. Lymphocytopenia is a reduced number of lymphocytes. Thrombocytopenia is a reduced number of thrombocytes or blood platelets, which means the person will have an impaired ability to form blood clots. They'll tend to bleed a lot. What can cause a reduced number of blood platelets? One thing is injury to the bone marrow where these platelets are formed, and what is something that can injure bone marrow is chemotherapy, treatment for cancer. And that's why people undergoing chemotherapy, it injures their bone marrow, their red blood cell count drops, they become anemic, and correspondingly tired and cold. Their white blood cell count drops. They are immunosuppressed because their white blood cell count drops and they are more susceptible to get sick. And their blood platelet count drops, so they tend to bleed a lot. And they bruise a lot. Okay, and then what follows next is commonly called a differential white blood cell count. In a differential white blood cell count, somebody takes a sample of blood, stains it, stains the cells. Those of you who had a micro class know all about staining cells. This is called differential staining. And then they examine 100 white blood cells under the microscope, and they identify of those 100 white blood cells, how many of them are lymphocytes, and how many of them are eosinophils, and how many of them are basophils. And if you've watched the video, I talk about the function of all these different types of white blood cells. Whether you learn them in micro or didn't learn them, you need to know them for physio. They're very important. Now, we'll just kind of start with the ones that we have the least of, basophils. Basophils we have the least of. Basophil white blood cells release two chemicals that both start with the letter H. Heparin and histamine. Heparin is a natural anticoagulant, and histamine is a chemical mediator of inflammation. You'll notice how evaluating blood is forcing us to review all kinds of aspects of this entire course. And what is the most important thing that when you go to the doctor or you're admitted into the hospital, what's one of the first things they want from you? They want your blood. Because this is how they're immediately going to start to evaluate what's going on, what's wrong with you. Okay, the eosinophils. Eosinophils are white blood cells that, exactly, they phagocytize allergens. They swallow up things you're hypersensitive or allergic to. Now, many people don't have any allergies. So you would have a low number of eosinophils. If you are a person who's allergic to lots of things, you've got lots of eosinophils. So when if you see an elevated eosinophil count, that is indicative that somebody has allergies. If somebody has hay fever, the eosinophil count goes up. If they've got asthma, their eosinophil count goes up. Okay, the monocytes. The monocytes are the big phagocytes. They're known as macrophages or monocytes. If you had micro, I know you learned about monocytes. All right, and so they swallow up bad guys, bacteria and viruses. We're not going to worry about bands. Lymphocytes. Lymphocytes make up about 25% of all of our white blood cells. Yeah, I talk about that in the video. So 1 out of every 4 white blood cells is the lymphocyte. Lymphocytes, as I describe in the video, are different than any other blood cell because all the blood cells are made in our bone marrow, but not lymphocytes. They're made in our lymphatic organs. They're made in our lymph nodes, in our tonsils, in our appendix, in our spleen. All right? We actually mentioned that for the exam we just took. It was on page 171 on cardiovascular physiology, right at the beginning. Anyhow, under functions of the lymphatic system. So her lymphocyte is normal. If her lymphocyte count was higher than normal, what do you think that means? An infection. Lymphocytes are the principal white blood cells involved in your immune response. So if somebody's fighting an infection, especially a viral infection, their lymphocyte count goes up. That's called lymphocytosis. What if the lymphocyte count is lower than normal? That's called lymphocytopenia. We learned that term. All right? And what could cause lymphocytopenia? What did you have to know causes lymphocytopenia for this exam we just took? Cushing's disease, Cushing's syndrome, elevated cortisol or glucocorticosteroid levels, taking prednisone all the time, a synthetic glucocorticosteroid, because we said they suppress the immune system by lowering the lymphocyte count. So if somebody's on prednisone, you would expect a lower lymphocyte count than normal. They're immunocompromised. Now, some of you, even if you don't remember that, those of you who had micro, I know that a common subject, every microbiologist loves to talk about this subject. What disease can lower the lymphocyte count? Think of microbiology, for those of you who haven't. HIV. Did you ever hear about HIV in a micro class? They always talk about it. The human immunodeficiency virus specifically destroys lymphocytes, and there are different types of lymphocytes. Everybody remember from micro which lymphocytes are destroyed by the HIV virus? The helper T cells, the T4 cells. So it lowers the lymphocyte count, all right? And so they are immunocompromised, immunosuppressed, and it causes a disease called AIDS, acquired immune deficiency syndrome. You've all heard about AIDS. And you have to know about AIDS. Now, AIDS is not as prolific as it had been, all right? But if you're a future nurse or a future dental hygienist, don't you think you ought to know if they have HIV? You're going to handle them a little bit differently. All right, now, polys. So what the hell are polys? So if you've watched the video, we talked about this. I'll just remind you where we discussed this. On page 11 in hematology. So on page 11 on hematology, here we mentioned that the normal white blood cell count is 7 times 10 to the 3rd per cubic millimeter. We talk about leukopenia and leukocytosis. All right? And then we talk about polymorphonuclear-sites. Polymorphonuclear-sites, polys, are white blood cells that have multiple lobes. And we point out on page 13 that there are 3 types of white blood cells that are polymorphonuclear-sites: neutrophils, eosinophils, and basophils. But we really have very few basophils and very few eosinophils, so the majority of polys are neutrophils. So they're mostly small phagocytes. If you were to look on the next page, page 14, and these 3 types of white blood cells, the neutrophils, the eosinophils, and the basophils are collectively known as the granular leukocytes or polymorphonuclear-sites. The majority are neutrophils. Notice their nucleus, it's very weird. Polymorphonuclear-site. Back on our chart on 224, where it says poly, the majority of polymorphonuclear-sites are neutrophils. Neutrophils are the major type of white blood cell. 60 to 65% of all of our white blood cells are polymorphonuclear-sites or leukocytes. Notice she got 53%. This is the percent. Out of 100 white blood cells, 53 out of 100 or 53% were polymorphonuclear-sites, neutrophils. 38% were lymphocytes, right? 4% were monocytes, 5% were eosinophils, and 0 now basophils. That's all typical. Pretty normal. So I talk about that on the video. So all of these are in the normal range, and each of these have different functions, these white blood cells. Okay, so we've been talking about hematology and how to look at this data. Let's look at one last thing, and that's at the bottom. So it's something we've already looked at. So she must have been complaining that she was tired and cold and maybe gaining weight. So they actually, in addition to the regular blood tests, they don't always run your thyroid function. That's not one of the standard tests. These are the standard ones right up here. But they did test her. They ran this T4. That T4 is an abbreviation for thyroxin. And they measured her thyroxin level by radioimmunoassay. And they got 2.6 micrograms. You don't have to know the normal number, but obviously it's less than the normal range. So she has hypothyroidism. They also measured her TSH level, and they always do. They always do. Whenever they measure T4, they always measure TSH. Remember, TSH, thyroid stimulating hormone, is also known as thyrotropin. It goes by both names. I wish it didn't, but it does. So some hospitals and some doctors call it TSH, and some call it thyrotropin. There's no consistency. And we've got a really high TSH level, right? It's way higher. So who can explain why that TSH level is so high? There's no negative feedback because the thyroxin level is so low in the bloodstream, it's not inhibiting the pituitary gland from producing massive amounts of TSH or thyrotropin. Now, so how they get, this is the classic type, this is primary hypothyroidism. Her problem is her thyroid, not her pituitary. Pituitary is producing massive amounts of TSH. So in spite of all this TSH, the thyroid is not producing enough thyroxin. So the problem is the thyroid gland. So the treatment is to take Synthroid, synthetic thyroxin. Now, how they know how much thyroxin to give the person is they keep telling them to raise their thyroxin levels, keep taking more and more of this Synthroid. They're going to take a certain amount. They're going to run another blood test. They may need to take more and run another blood test. They're going to keep taking thyroxin, and as the thyroxin hormone level rises in the bloodstream, it's going to start to inhibit the pituitary, and the TSH level is going to start to drop back down into the normal range. So the way they know how much thyroxin to give you is to give you enough until that TSH level produced by the pituitary drops back down into the normal range. That's how they know, because that shuts off that feedback mechanism. Okay, so let's summarize. If we had shown you on the first week of this class this page, and we would have asked you, interpret it, explain what's going on in this patient, do you think you would have been able to look at this data and understand much? Probably not. But look what we could explain. All right, first off, one of the problems she has is hypothyroidism. So she's going to have to be taking Synthroid, synthetic thyroxin. That's one problem. That will help the fact that she probably is reporting that she's tired and cold all the time, among other things, maybe gaining weight. What's another problem? Another problem we noticed she had is she has hyperuricemia. She has elevated uric acid levels in her blood. Uric acid accumulates in the synovial joints, especially the synovial joints of the big toe, causing inflammation and pain. It's a type of arthritis called gout or gouty arthritis. So she's going to take medication to lower those uric acid levels. You don't have to know this, but the drug they give is allopurinol, is one of the drugs. That helps reduce the uric acid levels. But I would say the most serious problem that she has, just based on her blood work, is those really high levels of cholesterol and LDL. Because those are red flags that she's at high risk of what's called coronary artery or coronary heart disease, which is a high risk that a coronary thrombosis, a blood clot will form in those coronary arteries, obstructing and stopping the flow of oxygenated blood to her heart. And as a consequence, part of her heart will die. And depending upon how much of her heart dies, she may or may not even survive it. That's called, in lay language, a heart attack, or clinically an MI, a myocardial infarction. She's got to be taking drugs to lower her cholesterol levels and try to lower her triglyceride or fat levels, and she may need to take drugs that reduce the risk of forming blood clots, like a blood thinner anticoagulant. So I think that now that we look at this is kind of impressive. We can look at the most common blood tests and start to see what these chemicals indicate. And what does it mean if these chemical levels are higher or lower than normal? This is the data that clinicians use to assess patients. And so we've made a major headroad in a quantum leap in our clinical understanding. We've gone way beyond just anatomy and what an organ looks like to understanding how the human body works.